if this is your first time, and you're just checking in with the group for the first time tonight, I would let you know that the second Wednesday of the month is our men's only session. And that would be a good time for you to join the group. It's the second Wednesday, the same time, 7 o'clock. And so if you have not, you've obviously signed up this time. So you'll just use the same process to join our session in April, whatever day that is. But it's the second Wednesday anyway of the month. I will mention, just as an aside, I had talked about participating in the seminar for the Prostate Cancer Research Institute. They had their mid-year meeting last Saturday, and I was not able to attend, but I did post in the forum area of our website a link to the entire program. It's 7 hours of video. So they basically videoed the entire program and put it on their website. And the agenda is there also. So you can look at the agenda and figure out which sessions you want to do. It was probably 4 hours of presentations, somewhat like we're going to have tonight, on various topics. And then there was a long time allotted for questions and answers. So you can skip to the questions and answers, or you can look through some of the presentations and watch those. But the website link there is on our website in the forum area. So let me introduce our speakers tonight. We have two folks, as soon as I can figure out where I put them. Two folks, Nicholas Little and Elise Bendik. Both of them are licensed genetic counselors. And so they're going to talk to us about genetics and particularly, I think, genetic testing and how that can be of aid to people. We've talked about this in the past, about getting your samples tested, and I think they can enlighten us a lot on that. So they both worked with oncology with cancer patients, and my wife had breast cancer quite a long time ago, and she went through the genetic testing process to find out if, in fact, she had any genetic disposition to breast cancer, because we have 3 daughters. And so it was very helpful to go through that process, meet with the counselor after the test results came back, and then talk about what the results mean and what the next steps might be for you personally based on what came out of the testing. So I look forward to hearing from Nicholas and Elise, and I'll turn it over to them.
Well, thanks, Ed, for the nice introduction. We just wanted to tell you all a little bit about ourselves and maybe get a feel for the group before we get started in the presentation. So again, my name's Elise Bendik. I'm a genetic counselor. I work at TriHealth. I've been there since 2018, but I've been practicing since 2010. Primarily, I've been focusing on patients, in the oncology arena for about the past 7 years, and have been working both in patient-facing roles in clinic as well as with a genetic testing laboratory. And so particularly, I have an interest in, talking with men who've had prostate cancer. I work on the genitourinary cancer committee within TriHealth, and we're just really trying to, improve understanding and awareness of genetic testing, both, directly to patients as well as to providers.
Yeah, my name is Nick Little. I'm also a cancer genetic counselor at TriHealth. I started at TriHealth in this role around when I graduated in 2019, and I've been in this role since. Similar to Elise, I have a lot of interests and certainly continuing to educate the community as well as providers about genetic testing and how those results can be helpful for yourself as well as possibly your family members, in terms of current treatments and possible screening recommendations to consider in the future.
And so I have to say, as a group, your reputation precedes you. We've heard you're a very well-educated, well-informed group. And so just to maybe give us an understanding, kind of the baseline level of understanding on genetic testing, and it sounds like you've had some presentations on this before, is this a topic that is somewhat new, or you feel you've heard quite a bit about, or you might have some questions, just to maybe help us gauge how much detail we should go into?
I think all of us have had some type of, when we've met with our doctors, we've been told we want to get genetic testing and been introduced to maybe 3 of the companies, Oncotype DX, Polaris, I can't recall them. But beyond that, maybe we don't have a good education as to what's being done, what the difference between the companies is.
Okay, sure.
And, I had cancer initially 5 years ago, and I did have my sample tested, but it was after the operation, so the insurance didn't want to cover it, and but it only ended up costing me about $150 instead of the $5,100 that they originally charged, and so it can happen, and I wanted to have a feel for exactly what the cancer was and how aggressive it might have been. Mm-hmm. And we have been recommending that new guys have their biopsies sent in and have it tested, mm-hmm. so they can make a better decision.
Okay, good. Well, thanks for sharing.
I have a comment to make. I go to the urology group. Dr. Delworth is my doctor, and he suggested that I have actually 2 genetic tests. They were both done with blood. I don't know all the details, although I think one was for specific genes like the BRCA gene, and the other one was for the cells in the tumor itself. Both of them turned out to be negative. So I'd still like to know what it was that I was actually tested for, if you can even tell from what I'm saying right now. But specifically, if I don't have a genetic component to my cancer, what therapies should I not be looking at? Like, are PARP inhibitors something that would be relevant to me or not if I didn't have any genetic positive tests? Are there others that somebody might suggest or hear about online, but that I shouldn't pay any attention to because they're not relevant to me?
Mm-hmm. Sure. So certainly something we can touch on. It sounds like I'm hearing a lot about maybe the genomic test to see how aggressive your tumor is to help guide your decision for how to treat it. Also, I'm sorry, am I getting an echo? Is that a little bit better? And then also, the test to see, is it something inherited that runs in the family? And then a test on the tumor as well to see, are there any genetic markers that might guide your treatment or therapy? So again, we can talk mostly to, around the testing. Sometimes the treatment is a little bit out of our area, but certainly we can guide you to ones that might be linked with certain genetic changes. And can you guys hear me anymore? It sounds like it might have cut off.
I can hear you.
Okay, good. All right, so just to get started, again, we're going to talk about some of the updates in testing and just a little bit around, hereditary prostate cancer risk. And so again, here you get to see a picture of us when we knew we were going to have our picture taken versus these days of COVID. But again, nice to meet everybody, and thank you so much for letting us join you. So just a little bit of a background, again, kind of, what genetic counselors do and sometimes, what they do not do. But a genetic counselor, we have advanced training in medical genetics and genetic counseling. So in most cases, that's a master's degree. Cincinnati has a genetic counseling program, so there's a lot of genetic counselors in the Cincinnati area, which is nice. It's kind of our role as part of your medical team to help you understand what is your risk for a genetic condition. And so genetic counselors have different specialties. You heard myself and Nick talking about how we've been specializing in oncology care, but also times you might hear of genetic counselors in other areas of medicine, such as prenatal, pediatric, cardio, genetic testing. And so part of what we do is, we do a risk assessment. We often look at patients' medical history and family history of cancer and, see what might be the best genetic test to help you obtain the information that you want. It's not always a test that, you just go ahead and get done, because not everybody wants to know information about cancer risk running in the family. And there's also some choice in, how targeted or how comprehensive of testing you can get done. So that's why we always kind of pair it with what we call genetic counseling. Often meeting with a genetic counselor, oftentimes beforehand to talk about the test to get ordered, and particularly afterwards to help you better understand what your test results are in terms of, again, for you and for your family. And so, again, it's not only working with you and, your family, but also your medical team to help understand, does that have implications for your treatment? And so we often get the question, is cancer genetic? And to some sense of the word, we say all cancer is genetic because it's essentially an accumulation of many mutations. And so if you think, cells normally progress through the cell cycle, there are certain genes, we call them oncogenes, that tell the cells how to keep growing. And then we have some genes, tumor suppressor genes, that tell the cells to stop growing and dividing. And then we also have DNA repair genes that, if during that replication process, there's a change when they're making that copy of, identical copy of that DNA, if there's a change, it should repair that. Or, if it can't be repaired, that's kind of when you see sometimes cells dying off. And so, again, you can kind of see in the picture, it's once cells acquire some of these abilities to kind of grow out of control that we see cancer developing. And there's a lot of different ways that, we can get these genetic changes. Again, just the cells dividing in themselves is one way over time, as, aging is one of the stronger risk factors for cancer, that we can see cancer occurring more often, as well as some, the environmental or lifestyle factors that can accumulate over time. And of course, we'll focus on heredity. And again, that's not only these more rare cancer syndromes where it's a genetic change that you inherited, but also some more minor risk factors, such as, did you have a brother or a father who had prostate cancer, as that can come into play and increase somebody's risk to develop cancer. And so essentially where we see that some families who carry inherited changes, cancer happens earlier in life, we kind of call that linked to the way that these genetic changes are inherited. So if you remember back to, learning about your genes, genes are inherited on chromosomes. And we all have 23 pairs of chromosomes, one copy from mom, one copy from dad. And so you get half your genes from your mom and half your genes from your dad. If you happen to start off with a genetic change that's inherited in every cell in your body, it's one step closer to that cell being able to acquire those mutations to go down that pathway to cancer. And so you can see that's where the kind of idea is that hereditary cancer causes a higher risk, and sometimes is at younger ages. Now, in talking about the different types of tests that you can have, again, we kind of differentiate. Is it a test that's done on your blood? And sometimes that can also be a saliva test, but essentially we might call that germline testing. That's looking to see, are any of these genes inherited in the family? And so if a change is inherited, you expect it to be in every cell of your body, including in the tumor cells. Tumor testing looks at acquired changes. So again, some of those genetic changes that just happen over time. And again, because there can be so many different changes, often, we say no tumors are alike, but if there might be some shared changes in those tumors that we know might be responsive to therapy, or, kind of give us an idea of other indicators, that's sometimes what that testing on a biopsy sample would be. So when you're diagnosed with prostate cancer, a lot of times they might talk with you about like that Oncotype DX test. A lot of those tests look at a small number of genes, around 3 genes, that can help determine, is your prostate cancer more likely to be aggressive? And then based off of that, you might be a little bit more inclined to consider something like radiation therapy or, possibly surgery or kind of going down that route. Versus if those, genetic markers and those few genes that are tested do not show it's likely to be an aggressive cancer, that's where you kind of get that number where it says, that it's estimated that you can go this long without your cancer, being spreading or metastasizing. So that gives you a gauge in deciding what therapy to go into. The other type of tumor test is when it looks at several hundreds of genetic markers that we know more broadly can be linked in cancer treatment. And so, kind of the idea is if you better understand what is driving the cancer, you better know how to attack it, and sometimes that can guide precision medicine. For example, a lot of prostate cancers are kind of androgen fed, and that's why one of your main therapies can be androgen deprivation. Some of the other markers, which we'll kind of talk about later, might be some changes in genes that cause your cells not to be able to correct that DNA damage. And again, that's where we talk about doing some precision medicine. And so again, we talk about a tumor biopsy, but you might also be aware that sometimes that can now be done on a blood test as well, because the thought is some of those tumors shed their DNA into your bloodstream. And so you can also do testing on a blood sample, which they might call a liquid biopsy.
So certainly as genetic counselors, if we're meeting with patients prior to doing genetic testing, we specialize in trying to look at the family history, someone's personal history, to determine could the cancer in these cases be hereditary or, a mutation that's been passed down in the family for quite some time. Some of the things that we look for in particular in the family would be younger ages of diagnosis, someone in the family having multiple cancer diagnoses, more rare types of cancers, things like ovarian, pancreatic, male breast cancer, and, more aggressive or metastatic prostate cancers. Sometimes we can see certain ancestry groups having just a higher statistical chance to carry some of these genetic risk factors. In genetics, we call those founder mutations. And when it comes to hereditary cancer risk, usually we think about the Ashkenazi Jewish population in particular, Icelandic, and certain other ancestry groups. You'll see on this pie chart here, that most cancers are sporadic, where, it's likely a combination of lifestyle, diet, environmental exposures, those random mutations that can happen over time, in individual cells. Only about 5 to 10 or as high as 15% of cancers can be in that hereditary group, where we do a blood test to look at the germline genes to see, is there some type of mutation being passed down in the family that's putting family members at a higher risk, in the first place to develop some type of cancer. The main differentiator between the hereditary and familial group here is, say maybe there's a number of these different signs for hereditary cancer in the family, but we do germline testing when we get all negative or normal results. It's possible that maybe there's some type of gene that we're not aware of or not able to test for at this time. So that's when you and your doctors, may consider, a strong family history of cancer and doing screening differently for certain family members, simply because of a strong family history. As an example, these BRCA1 and 2 genes come up pretty often. They're most well known for their risks for female breast cancer, ovarian cancer, but also prostate cancer for men, as well as male breast cancer, and sometimes pancreatic cancer in a family. When we get this type of results, we have pretty good data to show these different risk ranges for what those lifetime cancer risks might be. Someone can certainly have one of these mutations and never develop a cancer history in their lifetime. But because they have that higher risk than the average person, we would consider screening them differently, than we would someone who doesn't carry one of those mutations. Like I alluded to earlier, usually when we find one of those germline mutations, it's something that's been passed down in the family for quite some time. If we found that type of result for you, usually close family members, siblings, parents, children would all have that same 50-50 chance, or, flip of a coin, heads or tails, to carry that same change. And oftentimes, patients usually have a lot of questions about, risk to close family members. And those are things that we, oftentimes discuss when we get results. When we're talking about prostate cancer in particular, we know that there are some genes that we see, most commonly for that type of personal or family history. In the data that we've seen so far, the most common genes that we see related to prostate cancer risk would be that BRCA1 and 2 gene, a gene called ATM, CHEK2, as well as a few of these other genes listed here, PALB2, HOXB13, and MSH2. On the very right, you'll see that these genes can be related to, a few different cancer types and not just prostate cancer. And oftentimes that's something that we're reviewing with patients either before and or after testing to talk about, should we consider doing cancer screening for other possible cancer types in the future for you or your family members. So, historically, how did your medical providers determine, who should get genetic testing and who exactly is it helpful for? We oftentimes are using evidence-based criteria to determine, if we were to test someone, who's the most likely to test positive. And this is because historically genetic testing has been expensive, historically we're testing, usually one gene at a time. Typically when we're thinking about insurance coverage, we're wanting to make sure that the patient meets medical criteria for that test to be covered by insurance. And usually insurances were primarily focused on BRCA1 and 2 in those guidelines and what's considered, a billable covered test. More recently, there's been a shift to not only offer testing more often, but also offer more broad testing. There's data that shows that it's more cost effective to test for a number of different genes at the same time. We call that a panel test. And our criteria, who we should consider for genetic testing has also increased, making it more accessible for people than it has been in the past. And something that someone brought up, before we started speaking with you all today, is that usually testing is now at a lower cost. Most of the patients that we work with, pay between $0 and $250 for testing.
And so if we kind of want to think, having been diagnosed with prostate cancer, when do you consider genetic testing, or what are the current recommendations? Usually what we reference are the guidelines that are established by the National Comprehensive Cancer Network. And these are actually, guidelines that anybody can have access to. If you just go to nccn.org, you can create a login and then have access to all of the, medical guidelines. With prostate cancer, when it's genetic, there's more of a bit of a predisposition to have an aggressive type of cancer, or a cancer that's more likely to spread. And so in that case, when they see prostate cancer that's aggressive or advanced stage, because that can also help guide therapy, doing genetic testing, again, that's an indication that you should consider getting genetic testing. Certain family history, again, as Nick was going through all those other cancers, that can be linked with some of the common genes. If you have a stronger history of cancer otherwise, maybe you don't have necessarily an advanced or an aggressive prostate cancer yourself, but if you've got women in the family who've had breast cancer, particularly, multiple women or at younger ages, again, something like a rare cancer like ovarian or pancreatic cancer, just having any relative with one of those diagnoses that's closely related to you. As well as, sometimes if you also have a strong family history of prostate cancer, particularly, if you had a brother or a father who had prostate cancer at maybe a younger age, under 60, or if it was an aggressive type or that they passed from. In the past, again, what we commonly most tested for was BRCA1 and BRCA2. Now we talk about doing panel tests, which is essentially looking at a large number of genes that can be linked to different cancer types. And so if in the past you only had BRCA1 or BRCA2 done, you're also eligible to get what we would call update testing, where for one, we can look at BRCA1 and 2 again, and maybe with updated technology or testing techniques, we can pick up a rare mutation that older testing could have missed. And two, it's often looking at other genes that we now know can be linked to prostate cancer. Some ancestry backgrounds we know might have a higher prevalence of certain genetic changes. One commonly that we think of around BRCA1 and 2 is if you're of Ashkenazi or Eastern European Jewish background. And so while we know in the general population, it could be in the range of maybe 1 in 300, 1 in 400 chance to carry a BRCA mutation if you don't take anything else into account. If you look at individuals who are of Ashkenazi Jewish background, that number bumps up to about 1 in 40. Now also say you've had somebody in the family who's tested positive, or you had heard they had a positive genetic test, the type of test for hereditary risk, that's also another reason to get tested. And something interesting to kind of talk about is, what if you had a tumor test that just looked at the tumor and it saw a mutation that we know can be important or can run in families as well? So the two tests, the way they kind of interact, if you just had a test that was done on a biopsy, and again, not to tell how aggressive your cancer might be, but one that looks at several hundred different genetic markers. Many of those genetic markers, if they're also inherited and in every cell in your body, can cause a cancer syndrome. Now, although I mentioned before, when we talk about if something's inherited, it should be in every cell in your body, that test of the tumor won't necessarily always pick up those genetic changes that can be inherited too. Now, sometimes when you're looking at the tumor, they can incidentally pick up something that might have, that could be inherited, and they might then recommend that you get genetic testing to see, is that true? Is that just confined to the tumor, or is it something that you inherited? But not always will those tumor tests pick that up. In some cases, tumors just have so many different genetic changes in it. There could be a large piece of DNA that's missing or been deleted or rearranged. And within that missing part could have been the genetic change that runs in the family. Also, sometimes the tumor test isn't quite as thorough as the hereditary test. And so sometimes they'll look for the more common types of sequencing mutations, but they aren't able to address those like deletions, duplications, rearrangements, which sometimes are more rare. So again, it's not, sometimes one test can be done in place of the other. Sometimes they're both complementary tests. And historically, when we were talking about genetic testing, it was only offered to patients who had advanced cancer or metastatic cancer. A lot of other studies now are looking at, well, what if we, testing has become more accessible, the cost is lower. What if we just tested a more broad range of patients? How about anybody with prostate cancer? Would it still turn out that it's really only those patients with the advanced or metastatic prostate cancer where we're picking up the mutations? In earlier stage cancers, we're really not seeing them being hereditary. And it did turn out that, one of the earlier studies back in 2016, where it was a large study looking at just men with, metastatic prostate cancer, did come back with around, 12% of the time patients will test positive for a mutation that runs in the family. Some more recent studies, again, have kind of opened up that testing to, look at as early as stage 2, stage 3, as well as stage 4 cancers, which you'll kind of see on the right in that table there. And the positive rate continued to be right around 10%. So regardless of, what stage cancer the patients were diagnosed with, still found about 1 in 10 men was testing positive. Same thing for another study that looked at, well, what's the positive mutation rate if we just go by Gleason score? And again, a Gleason score of 6 is kind of one of those where the doctors might be more comfortable talking about with you, just active surveillance, versus over 7 is where you might want to do more of an informed choice on how you go forward. And again, they really found that in both scenarios, they were finding positive mutations. And again, because some of these positive mutations can be associated with a more aggressive type of cancer, that's really helpful information to know when you're talking about, well, what if you have a low Gleason score? So it can be really helpful in informing that decision process with your doctors. And so, again, when we talk about genetic testing, we're kind of seeing with prostate cancer, we tend to see a lot of the same mutations or the more common mutations. By far BRCA2 is one that we see more often, as well as, again, BRCA1, CHEK2, and ATM. And in the past, it wasn't for all of these genes that there would be any recommendations regarding prostate cancer. So if you found it in the family, if you found that you carried one of these inherited mutations, a lot of men would say, I want this information for my siblings, for my children. And particularly, we, oftentimes hear men saying, I have a daughter, I would want her to know if there's a higher risk for breast or ovarian cancer, because it really does significantly change how a woman would be followed. Women often start mammograms and breast MRIs in their mid-20s. And of course, there's ways to reduce cancer risk. Like for ovarian cancer, it can be a tricky cancer to catch. And so some women might choose to have their ovaries out, or same thing with, breast cancer. Some women might have a risk-reducing surgery to kind of help mitigate that risk. But also, again, for men, they're coming up with more genes that now have guidelines saying that, prostate cancer in these cases should be started around age 40 and should be considered annually, which, in general, that's not always the case. So you can certainly see how early on that can have implications for family members too. So, on the right, what we're kind of looking at is in the blue at what age men are diagnosed, and then on the right at what age they have their testing. And so you can kind of see there's a shift in the blue that men tend to be diagnosed at younger ages, and then they tend to be tested at older ages. And while sometimes we talk about genetic testing or inherited risk testing in terms of, sometimes the more advanced cancer, where it might have treatment implications for that, it certainly can be a missed opportunity if men aren't diagnosed as earlier up front, given, what it can mean for family members. And so, again, how can this kind of impact, treatment and screening in the family and across the spectrum of different disease states where patients are diagnosed? So I kind of mentioned, about early screening and recommendations for family members around prostate cancer. Again, with the active surveillance, kind of better informing that choice around, do you want to do active surveillance, or might you want to go on and consider more of a treatment or therapy for that? As well as, clinical trials are always something to consider. They have that as well around early detection or monitoring, looking at new ways to kind of screen men, not just with PSA or DRE, but maybe looking at MRI as a screening technique. And then when we kind of shift to the right and look at, the more advanced stages of cancer, we know that there's some approved therapies for men who have what we call metastatic castration-resistant prostate cancer. Again, that's, a smaller group of men that kind of progress to that stage and might have progressed on different therapies. But for certain genetic markers, particularly BRCA1, BRCA2, ATM, there's accumulating data that can, be a beneficial therapy.
Sus. Okay.
And I'll just say, For the other cancers as well, again, sometimes we think of it at that most late stage, but there's certainly clinical trials that are looking at, rather than just doing certain therapies later on, maybe moving those earlier in the treatment stage and doing combined therapies as well too. Is this slide me, Nick? I forget.
Yeah, sorry.
Okay, sorry, that's why I was pausing there. So again, the therapy I think we hear a lot about, and it had been mentioned before, PARP inhibitor treatment. And so, initially we started hearing about PARP inhibitors several years ago, and kind of around, again, BRCA1 and BRCA2 mutations, or sometimes we hear BRCA-like cancers. Initially, we saw a lot of approvals for ovarian cancer patients. Following that, women with metastatic breast cancer. Following that, pancreatic cancer. And then now most recently in May of last year, we saw 2 PARP inhibitors that were approved for men with, again, that certain metastatic castration-resistant prostate cancer. Now, you see the 2 different drugs. There's olaparib and rucaparib. What they showed in the studies was that they can have a better response in shrinking tumors, and then a better response in keeping tumors from progressing. While the majority of the response and for rucaparib is just for BRCA1 and 2 approval, either in the Germline or inherited, olaparib has a little bit more of a broad indication, but the most magnitude of benefit and what's been most proven is to be effective in men who have the BRCA1 or 2 mutations, or ATM. Now, again, those can either be something that's inherited, or it can be something that's identified in the tumor biopsy or liquid biopsy. You often hear of there being a larger number of genes that, in addition to BRCA1 and 2 and ATM, which sometimes will be tested for, they call them homologous recombination deficiency genes. So again, it's more that DNA repair type of function that, because they're mutated, is not correctly happening. And so the thought is that you kind of take advantage of that, and they'll call it synthetic lethality, where we know that cancer has a lot of genetic changes happening, and a lot of these therapies like radiation treatment are also going in and adding in additional genetic changes or breaks in the DNA. Now, sometimes cells can recover from that because they have different mechanisms to repair that DNA damage. One of those mechanisms for double strand breaks in the DNA, and again, DNA, you kind of remember, is that like twisted ladder, double helix. For changes that go through both of those, BRCA1 and BRCA2 are very efficient at fixing those changes. And then if it's a DNA break in just one of those sides of the ladder, PARP is the protein that helps with that. So if we know in patients that have BRCA1 and BRCA mutations, their functionality of fixing those double strand breaks is not happening, we can go ahead in and add what we call a PARP inhibitor and inhibit that protein PARP that should be helping, again, repair those genetic changes. And while in some cases genetic changes can drive cancer, when a cell gets too overwhelmed with DNA changes, again, the idea behind radiation therapy, chemotherapy, the cells die off. And so it's a way to increase how cells are targeted with a therapy that's very specific to what's driving that cancer. So again, I think there was a question, if you don't have one of these mutations, is this a therapy to think of? And I think not right now. Again, it's very precise in the way it works. So they haven't really done any studies to see, although that, in anybody who has prostate cancer, would this be something helpful? I think that's something that they have shown in ovarian cancer, and it's possible that could be something down the road. It's just tough to say, but right now it's just very specific. Kind of similarly, if you carry some of these genetic changes like a BRCA change, considering a platinum chemotherapy might also be something better suited. And then if you've heard of a condition called Lynch syndrome, which primarily you see a high risk for colon cancer and uterine cancer, but can also have an elevated risk for prostate cancer. That's caused by genes that impact how DNA is repaired. And so sometimes you'll hear about an immunotherapy, PD-L1 therapy, or Keytruda, because again, these cells have a lot of DNA changes. They look very different from normal cells. So they recruit your immune system to kind of attack those cells that don't look like they're, that look abnormal.
Yeah, so oftentimes we get questions, whether it be with our patients or, community members that we're speaking with and doing this type of education on, if you would like testing, or maybe if you have had genetic testing and would like to talk more, with a genetic specific provider about those results. Oftentimes your medical oncologist could refer you to a genetics clinic. There are other resources to help you find, for instance, a genetic counselor. The National Society of Genetic Counselors does have a Find a Genetic Counselor resource on their webpage. So that's something that we always share. A common theme, with the decrease in cost to genetic testing, and something that's making it more accessible to a larger group of people, is that there are a number of genetic testing laboratories that are both CLIA and CAP approved. And they have, friendly billing policies where, usually patients that meet that insurance criteria for the testing to be covered, usually the out-of-pocket cost is between $0 and $100. And for those where, testing is denied or their cost is above that $100, oftentimes many labs nowadays have some type of financial assistance plan that patients could apply to. In addition to that, for our patients who are just genuinely interested in seeing if there's some type of hereditary cancer risk in the family, but they don't meet their insurance criteria to do testing, there are several labs that offer self-pay options where, the billing wouldn't be through your insurance, but, with a credit card or check. And usually that's around $250. We did want to mention that some labs do also offer sponsored or no cost testing. And oftentimes, especially now for prostate cancer, we have an example from a lab called Invitae here. They have more broadly widened the criteria for men that would qualify for a sponsored no cost testing for germline genes. So we wanted to highlight that there as well.
And I think as well too, it's nice to mention, you might have heard of family member testing programs too. So for a lot of the hereditary, risk, as we were talking about it, if you're positive, your close relatives, it's, up to 50% chance that they could also test positive. A lot of labs will have a certain window of time where your relatives, if you test positive, can get tested to see do they or don't they carry that same genetic change. And there's no cost for their test. It's usually around 90 days. And again, it's if they use the same lab and they have a copy of your test report. So that can be a nice, offering for family members.
Yeah, and certainly at this time, if anyone has any questions about what we presented or anything else that we can help answer for the group, we'd be more than happy to do so.